So let's get on with our story. So I used some of the slides from my good friend Dr. Wong, so many thanks to him. But the questions are mine and the literature review is also mine, so don't blame him. So this is a 63-year-old woman who has the metabolic syndrome. She's Malay without a history of drug allergy, non-smoker, non-drinker. Quite a large BMI. And these are some of the background medical conditions. She's hypertensive, hyperlipidemic. She's got diabetes and chronic kidney disease, ischemic heart disease. Okay, so I think these are some of the things. She was found to have ischemic heart disease on coronary angiography some years before. This almost 10 years ago, I think, but it was for medical management. Okay, so now she comes with gum bleeding, thrombocytopenia. This is a few years before the current visit, and she was found to be hepatitis B, hepatitis C negative, autoimmune screen also negative, and so they came up with the diagnosis of non-alcoholic fatty liver disease. Cirrhosis on ultrasound, no focal lesions, spleen is enlarged. And then in August, she comes in with multiple episodes of hematemesis and is found to have a distended abdomen. So this is the workup. Gastroscopy shows varices, as might be expected. She had ascites on clinical exam, and when they tapped her, there were white cells, but the culture was negative, so graded as child C10 and male 15. So that and deemed a suitable candidate for liver transplant. So swabbed positive for both MRSA and VRE. Okay, so now we're talking about the admission that we're interested in. Symptomatic ascites, acute on chronic kidney disease, rectal varicose bleeding. That was an admission about 2 weeks ago that lasted 10 days. And now she comes in for what looks like a very elective procedure. They want to drain the ascites, right? But then she says she's been coughing for a day or two, no hematemesis, but the abdomen is getting more distended. So this was predicted by the liver team, and that's why they're doing this drainage. Looks very well, vital, stable, alert and responsive, but that jaundice, no flap. Chest is clear, abdomen has got shifting dullness, and she has leg edema. So that's a chest x-ray. You have to remember this chest x-ray. Okay, these are some of the investigations. Creatinine is 121. In our hospital, we use micromoles. So that's about 1.1, 1.2 if you use milligrams. Not acidotic, bicarb is 22. Mild hyponatremia, potassium all right, urea and chloride okay. Total protein 69, albumin 35. Bilirubin, that's not bio lah. Bilirubin is 600, phos 105, ALT, AST not too bad, but AST is slightly elevated. INR is 1.9. PTT, however, is prolonged. Hemoglobin is 7, white cells 9, platelets 101. And because she had very mild, some cough, but the normal chest x-ray, normal chest exam, a throat swab was done to look for viruses and they were negative. So the cope loop was inserted, and the serum to acetic fluid albumin gradient is very large. So this is just a transudate, and culture was negative, right? So this is how she progressed. Basically, she became more breathless, became more edematous, and as you can see, there's a progressive rise in the creatinine. So this is HRS, they diagnosed hepatorenal syndrome. And then she's a bit more breathless, so the chest x-ray is done. And I suppose most people will call it congestion. And that's the creatinine. As you can see, it is going sort of stable after they put her on terlipressin. Okay, day 14, this is some years ago actually. Progressively more breathless, more tachypnic, temperature 37, 99% on 4 liters, heart no murmurs, with some minimally raised JVP maybe, some rhonchi and some crackles. Abdomen remains distended, she's still edematous. So as you can see, her white cell count has gone up to 14. Bilirubin is very high now, 600. And creatinine, well, creatinine appears to have improved after terlipressin use for hepatorenal syndrome. And because of that, we bring her to the high dependency unit, and this is the chest X-ray. I don't know whether it projects well. Maybe we have to switch off the light to get a good look. But what is the next step? So that's the first Slido question, right? She's cirrhotic. She's got hepatorenal syndrome. She's coughing. She's got dyspnea. She's got a low-grade fever and an abnormal chest X-ray. And she's not well, so the team has brought her to a high dependency unit. That's one step below the ICU in our hospital. So what would you do? They've called in the ID team to be involved in her care from this point on. Still moving? Okay, are we done? Okay, so I suppose there's no correct answer. If you work on the interactive cases in the New England Journal of Medicine, they're very kind. They don't say anything is wrong. They just tell you which appears to be a more appropriate choice, right? So cryptococcal antigen is actually a reasonable choice. Cirrhotics, I think there are increasing reports that you can get cryptococcosis in patients with cirrhosis. And she just came in. Well, she's been here some time, a bit odd, but if this were really community acquired symptoms, maybe in a liver patient, cryptococcal peritonitis is the most commonly reported in these cirrhotics. CT chest was the favorite choice, so I think that's something we definitely want to do because from the chest X-ray, I think it's very, very difficult. Right? She's breathless. We have to do this AP on the bed and all that. Intubate, well, I think we can leave that to the intensivist. Maybe not at this stage. She's 99% on 4 liters. Rule out COVID, of course, in this day and age, but this is a pre-COVID case. Start ambisome, I think maybe not now. We probably need a bit more evidence, either a blood culture, grain candida. Cirrhotics are also at risk of candidemia, or at least you need something on the X-ray that's a bit more suggestive of a fungal infection. Okay, so everybody wanted a CT chest, or 68% wanted a CT chest. So we'll have a CT chest. So very difficult to actually say what it is. Although I've taken a few cuts here. Some suggestion. Anybody has suggestions? Maybe the next one. Okay. This is an applied question. Depending on the suggestion, you will do certain things, right? Okay, so the CRIP antigen is negative. Okay, so maybe let's go back and look at this. Of course, I think if you're at the bedside, it's much easier for you because you have all the data on the computer and you have the patient in front of you. Um, I think there might be, I personally think there might be more than one process going on. This one in the middle might just be good old bacterial consolidation. You can see the air bronchogram going through. This one also, but I don't know about, where is it? I don't know about this thing here, which is very nodular. I don't know whether you would consider that nodular, whether that's part of the, you have to scroll up and down to see whether that's part of a bigger consolidation, I suppose. But obviously, there's a lot of concern for a fungal infection in this patient. Bronchoscopy and BAL are ideal, but she's teetering on the verge of being intubated. So either we intubate her and then do the BAL. She's thrombocytopenic from her liver cirrhosis. Or we can do one of these tests, but that's also a delay. So I think in the morning I said do the sophisticated investigation early, so everybody has taken it to heart. And yeah, indeed, we had a discussion with the patient and the family, and the ICU team decided to bring her to the ICU and do the BAL, and if she decompensates in terms of her respiration, just intubate her, right? Of course, like other ID physicians, you will escalate the antibiotics. And we also we gave her some ambisome. Okay, so these are the BAL, these are the results. The serum galactomannan was positive. The BAL grew MRSA. And the BAL also had a positive galactomannan. Yeah. So she's a liver failure patient with pulmonary aspergillosis. But unfortunately, her consciousness dropped, and we had to do a CT brain, and you can see the blood. Where's the blood? This blood. So unfortunately, she has bled, and she passed on. Okay, so the last question before I do a bit of a lit review is to ask whether or not you think, based on a case like this, cirrhotic should undergo screening either via galactomannan or PCR. Screening means every week put on a program of drawing blood and checking every week. Screening. Okay. Okay, let's move on. So let's go through some of the literature behind it before we come to that last question. So like I said in the morning, it is being increasingly recognized that patients in the ICU can develop invasive aspergillosis even if they don't have a malignancy. So this is one of the earliest studies. This is a center that has a very high autopsy rate, and they found that 15% of their autopsies, if you're talking about ICU deaths, had aspergillosis, invasive aspergillosis. And this is another paper where they looked at all the critically ill patients with aspergillosis. So you remove those who had some underlying malignancy, and you find that of the malignancies, almost all are hematological malignancies. But there were also people who were proven to have, who were shown to have invasive aspergillosis, and they didn't have a malignancy, right? So if again, solid organ transplants were recognized, so you can chuck that lot out. Various autoimmune diseases on immunosuppression, you can also chuck that out, because we do worry a lot about invasive fungal infections in these patients, and we'll be left with conditions like chronic obstructive lung disease and cirrhosis, and these are some of the emerging groups that we recognize to be at risk. Now, once again, this sort of association has been recognized for a very long time. I think this is Tom Walsh in a previous incarnation describing 3 cases of disseminated aspergillosis. Is just a case report. Subsequently, other people have managed to put together bigger series. This is a Chinese series from Zhejiang, and they defined, they look at all these people with ACLF, right? Acute on chronic liver failure, and IPA was defined by the EORTC guide. And what they found was that in all their patients with acute on chronic liver failure, some had IPA and some didn't. IPA is invasive pulmonary aspergillosis, right? And steroids seem to be a big factor here. So the independent risk factors for invasive aspergillosis were age, hepatic encephalopathy, and steroids. This is another paper. It's a French paper looking at a 10-year series. So actually, it's a very uncommon condition because if you think about it, over these 10 years, they had almost 1,000 patients in the ICU. Only 60 grew aspergillus from the respiratory samples. And using blot criteria, only 17 of 60 were diagnosed with invasive aspergillosis. So the blot criteria I showed this morning, right? The entry criterion is a positive culture from ETT or sputum, and then the rest you layer on the symptoms or signs, the radiology, and if you can't find the host factor, which is neutropenia or steroids, you have to resort to a BAL to look for a positive culture or to look for hyphae. And of their cases, only 2 were actually proven. These were diagnosed on lung biopsy and had cerebral abscesses on CT. I think this has been mentioned before by one of the speakers in the morning. Non-neutropenic hosts tend not to have a halo. Serum GM was not bad, positive in quite a few of them. And in this series, they found that if you also had chronic obstructive pulmonary disease, it was predictive of IA. So here is one of those series which show that if you have more than one risk factor, maybe there's some additive effect. And they were able to show that the cirrhotics who had invasive aspergillosis, of course, were more likely to die. Okay, so what's the role of screening? Somebody has actually done this in a formal study. This is in Austria. And they did twice a week serum galactomannan in all cirrhotics, whether compensated or not. And they found only 2 cases, right? So 2 out of 150 whom they recruited into the study. So the positive predictive value is like that. So it's dismal. And in fact, when the patients had respiratory symptoms, there was nothing. Clinical suspicion was a little bit better. Yeah, so basically they felt that you cannot do this in a screening program, but of course you can do it, when you clinically suspect that something is happening. Okay, PPV and all that are very, very low. Okay, so if you don't do it in the whole population of cirrhotics in the hospital, would you do it in those who reach the ICU, right? Is there any value in making sure that galactomannan is routinely added to BAL? Okay, this is in ICU, right? For those of you who work in Singapore at our hospital, we have BAL for the compromised host, and there's an automatic panel that the resident will click. But this is all ventilated patients who underwent BAL, so not necessarily compromised. Okay, so this is what they decided to do, and at the same time, if you're non-ventilated, they would do GM screening twice a week. And then they look only at the cirrhotic subpopulation. So they had 84 patients, and in the end, quite a lot, right? 14% with probable IA, giving GM, BAL GM sensitivity of 90%, specificity of 95%. And these are some analysis that didn't really become statistically significant, but there was a trend towards significance. And all the cirrhotics in the ICU who were found to have invasive aspergillosis died. So I think if you limit it to cirrhotics who are going to undergo BAL, that means there's some reason, then I think it's worthwhile making sure you look for fungus by adding the relevant test. Okay, I think the issue now is how to manage, right? Because a lot of the drugs are hepatotoxic, and many liver patients have very tenuous or precarious renal function. So all the available anti-mole agents, voriconazole, ambisome, are very, very tricky. So if you look back at the guidelines, they do not specifically address this subpopulation. So what have the various series done? So this is a series from Guangzhou, and they gave VORI-BD, but they didn't load according to body weight. They just used an empiric dosing regimen like that, only 100 a day, and they got troughs very nice within this range and managed to have a survival of 75%. Quite good, surprisingly. I don't know. These are the two cases in that screening program, and I suppose because they were screening, they picked up very early. They gave voriconazole. This is standard dosing. Managed to achieve range also, trough values also within the acceptable range, and both survived. But I suspect that these patients were treated very, very early because this is part of a screening protocol. And this is the study from Munich. I think this approaches reality according to my experience. And most of the patients receive ambisome. Only one received voriconazole. They didn't talk about trough values. All of them died. So I think this is a very gray area. We're all not sure what to do. So the question is whether or not you can use lower doses. The Chinese series use very low dose. So there's another series, another Chinese series that looked at it. In group 1, they look at, okay, this is not necessarily IPA. This is just looking back at people who had liver disease and who received voriconazole. So they look at those where the physician followed the recommended dosing, or 200 twice a day, and the group 2 will be those whose physician empirically decided to do 100 twice a day, just a low dose like that. Okay, so they found that actually the trough concentration was very high, above 5 in 68% in this group where you followed manufacturer's recommendations, and even at this level. When you use what is supposedly a low dose, more than a quarter had troughs above 5. And the incidence of AEs, these are adverse events, of course, much higher in group 1 than in group 2. So there is a risk, of course. And this is from King's College. That's a liver transplant unit, very big unit. And they point out that actually voriconazole can produce liver function, LFT abnormalities in patients with pre-existing liver disease. We don't need to look at all the details, but you can see all types of patterns and elevation in transaminases, a cholestatic picture or a mixed picture. And they felt that the predominant pattern was a rise first in the ALP, and then the transaminases while the ALP plateaued or fall. Isn't that a very interesting pattern, right? And when they use some of these published scores, it said that there was a high probability. Note that in some of these cases there was rash, jaundice, fever, and even eosinophilia. But these are, I suppose, biochemical abnormalities. Nobody's failure actually worsened, but it is a very risky thing when patients already have pre-existing liver disease. So they are very, very cautious. They say use with caution, and they advocate regular monitoring, or just use an alternative agent. Okay, what about isavuconazole? Is isavuconazole an option? The secure and vital studies, the registrational studies for voriconazole showed that voriconazole was better. Isavuconazole produced fewer hepatic AEs than voriconazole, right? So this is one. There are two papers. Both are very small. One is actually a case report only, suggesting that maybe you could. Now this is an early paper, C09, that looked at isavuconazole in patients with Charles A and B cirrhosis, and even then you find that there is some accumulation of levels, right? So these are healthy volunteers. That's the way the voriconazole levels will go down with time, and if it's mild like that, it's higher than the healthy volunteers. If it's moderate, there's even accumulation or retention of isavuconazole in the bloodstream. So, but this paper suggests that you could do it with TDM, but then we don't have, most people don't have an isavuconazole TDM. Okay, I suppose caspofungin is a third line option, and you can consider using that also. Ambisome can be used. Very tricky, of course, like I said, in patients whose renal function is almost always tenuous. Okay, so that's think fungus. In a cirrhotic, think of septate hyphae like aspergillosis. Thank you.